Hello everyone, this is Jack Wheeler. Welcome to my presentation on schizophrenia and other psychotic disorders. So the reading for this lecture, Halter, Chapter 12, DK, the psychology book from page 70 to 75. I do have to tell you, in the reading in DK, it mentions several times the treatment of cognitive behavior therapy for schizophrenia. And I just have to say that I don't agree with that because the part of the patient that's sick in schizophrenia is the cognitive part, the thinking part. And so I don't believe that's appropriate treatment for somebody with a thought disorder, which is another word for a psychotic disorder. Associated VSIM is David Carter, Part 1 and Part 2. There also will be on the exam on this lecture, there'll be a case study questions from the David Carter VSIM, both parts. And then there's a psychosis care plan that I included in the module. This is one we used at Herrick before electronic charting, and it has just a lot of the solid kind of basics that are part of a care plan for somebody with this kind of condition. All right, so just to look at the objectives, some of the typical behaviors that mark the very early symptoms, the prodromal phase of schizophrenia, and that's the prodromal phase. It's the disease has not really come out yet. That's what prodromal means. It's like the pre-disease of the disease, and so some places you'll see it marked with prodromal. As like the first phase of schizophrenia. Other places, and most places, don't consider the prodromal phase really the beginning. It's really the acute phase. The very first psychotic break is considered the first phase. But there is no official way of looking at that handed down by the American Psychiatric Association at this time. All right, so you'll need to understand and explain the difference between positive and negative symptoms in schizophrenia. Understand the common features of schizophrenia, included but not limited to thought broadcasting, thought blocking, ideas of reference, neologisms, echolalia, inertia, thought insertion, and thought control. There's also echopraxia, should be on that list as well. And then be able to differentiate between brief psychotic disorder, delusional disorder, schizoaffective disorder, along with other things like schizophreniform, those kind of things. Those are terms that you'll know by the end of this module. Know the difference between typical and atypical antipsychotics and be able to give several examples of each. Be able to recognize the side effects of antipsychotic medications. You can imagine, as a nurse, one of the most important things that you'll do is be able to recognize early on side effects of antipsychotic medications. One of my missions is that everyone that graduates from my class, wherever they go, whatever setting they work in, if they run into a patient with these side effects of the antipsychotic medications, they will be the first ones to identify them, because we're going to have a skills lab where we really go into depth. You know, it's very important to catch these early on. And I'm not going to name them all, but you can see them there on the screen. Then know how to explain the cause of schizophrenia to family members. Understand and explain the different types of hallucinations. So we have auditory, visual, tactile, where you can feel them, gustatory, where you taste things, olfactory, and then general somatic sensations. I've had, just from the general somatic sensations, kind of hallucination. I'll give you some examples. We've had even men that have a somatic sensation and a delusion that they believe that they're pregnant. We've had I had a female patient, adolescent, that she believed she was growing a tail. Um, so those are what we call general somatic sensation type of hallucinations. What kind of symptoms make a psychotic patient a high risk for suicide? Be able to explain the risk benefits and treatment protocol unique to Clozaril, the generic name Clozapine. Understand how visual hallucinations present differently in schizophrenia than they appear when there's an organic cause in delirium. This is especially important because sometimes our antipsychotic medications, if we give too much of them, they can cause delirium in a patient, and it's very important that we recognize it as delirium so we don't give more of the medication that might be causing the delirium. And that's a very simple way to tell that we'll go over. All right, of all psychiatric mental illnesses, schizophrenia probably causes more time in the hospital. It is very destructive to families, costs a lot to the government, and causes a lot of fear. These people. They're scary, especially if you don't know psychiatry and you don't understand what's going on with them. So it's probably the cause of schizophrenia. It's thought to be caused by a genetic predisposition and then brought out by environmental stress. Remember, early on in this course, we talked about the diathesis stress model, and that's diathesis is kind of like your genetic vulnerability, and then whatever environmental stresses are put on you, bring it out. Remember, with identical twins, if one of the twins has schizophrenia, the other identical twin with the exact identical genetics and in a lot of cases the same general environment only has the identical twin only has schizophrenia about 50% of the time. All right, the nature of the disorder. Schizophrenia causes disturbances in thought processes, perception, and emotion. With schizophrenia, there's a severe deterioration in their ability to function in the world. They can't really have relationships. They can't hold down a job. It's very debilitating. About 1% of people are considered schizophrenic, although I've looked at other statistics that said it was more like 1 in 40,000 people. So the 1% that they've listed for a lot of years, that might not actually be accurate. It might be much less than that. So phases of schizophrenia, like I said earlier, the prodromal phase, not really considered a true phase because the disease has not unfolded yet, but you will see that some references, some sites will consider that the initial phase. Frequently, it's mistaken for someone being depressed, and not it's usually not seen as a true as the start of schizophrenia until the acute phase happens. Then you can look back and see that there were some clues there. Um, the, Usually it's a teenager, so it's not unusual for teenagers to withdraw and go through depression and get a little weird sometimes. um, but then it's not when they start becoming outwardly psychotic. And so that's what will happen after the prodromal phase. There'll be an acute, what we call the first psychotic break, and the person is very out there psychotic and always requires hospitalization or should be in the hospital. Often the very first psychotic break comes along with a very serious suicide attempt as well, so that it's a very dangerous time in the person's life. All right, so hopefully once we get them hospitalized, find some medication that helps, get the environment stable, that we can actually get them onto this next phase where they're getting stabilized. And when we get them to the maintenance or residual stage, what we mean here by a new baseline is established. And what's pretty sad about schizophrenia is that the person is never going to be what they were before they had schizophrenia. And they're not, it's not like with bipolar disorder where you get them out of the extreme mood states and they're like themselves again. The person that truly has schizophrenia, they're never going to be as high functioning as they were before the schizophrenia, before the emergence of the illness. And so generally when they're in their maintenance phase, they still will have a little bit of symptoms, especially negative symptoms, which we'll talk about later, but they'll have, they'll still hear voices a little bit, but it'll be manageable, or they'll have some little delusions, but nothing that's really too disabling. But the condition itself overall is very disabling. Okay, so our planning, when they're in the acute phase, we want to keep them safe. Remember, like I said, they're at risk for a very serious suicide attempt, and we want to get them stabilized as soon as possible and onto the maintenance phase. In the maintenance phase, a lot of what we have to do is kind of help the family with their denial, because the family's going to want to blame it on drugs or blame it on something else. Um, it's very hard to accept that you're because that usually this happens, like for males, the most common time to have your first psychotic break is between 16 and 19. Females a little bit older, maybe like 18 to 22. um, and so it's very hard for parents to accept that this person is no longer going to be the person that they were. And so this can be heartbreaking to do this kind of education with families, but it must be done. They have to understand. Sometimes families will still send them off to college, just kind of hoping they'll snap out of it, or it's just a phase. But those can be a real disaster. When someone goes off to college, it's stressful on normal people to be away from their family for the first time. But imagine if you have a psychiatric illness like this, it can lead to a tragedy. All right, so the acute phase, um, we get everything evaluated. We've tried to find some meds that work. We give support and education to the family, because they're not going to have any idea what's going on. They're going to be very scared. They might be angry at the patient, blaming the patient, which is not helpful. We're going to have to supervise them closely because of the danger. Make sure they're taking in enough fluids, um, and make sure they're not at risk to be aggressive. So in the stabilization and maintenance phases, we're we're teaching them about their meds. We're trying to make sure they're not having too bad of side effects. We want to make sure that patients don't feel uncomfortable telling us about side effects, because they might leave the hospital and just not take them. We don't want them just tell us what we want to hear just to get out of the hospital faster, because they're going to end up coming right back. All right, and then try to get them hooked up with care providers, and then whatever activities and groups to try to get some of their socialization skills back. The prognosis is very poor for somebody that's qualified for the diagnosis of schizophrenia. It's very sad. They almost never return to their previous functioning before their first psychotic break. Usually when they have returned to their previous functioning, it turns out that they didn't have schizophrenia, that psychosis was from another cause. the factors that are significant for a positive prognosis, and positive just means not as bad. I mean, it's all bad, but it's the positive prognosis is not quite as bad. Is that they were high functioning previously. The onset was later, so for males, the onset is generally from 16 to 25, but really much more in the 16 to 19 age. So if it's like into the 20s, they're usually not quite as disabled. Females that are diagnosed with schizophrenia generally aren't, their schizophrenia is not as severe. Um, let's see, abrupt onset precipitated by a stressful event. Sometimes that, maybe, even if it does bring on their full diagnosis of schizophrenia, there's a little bit of the brief psychotic disorder, which we're going to be talking about later. That could have been superimposed on it, making it worse. If there's more of a mood disturbance, and if there's a brief duration of the active phase symptoms. So those active phase symptoms where they're really actively hallucinating a lot, very paranoid. If that is a brief time, then that's good for their prognosis. All right, so some predisposing factors. Genetics, that this is the Gemini is the what you're seeing there. Other predisposing factors. One theory suggests that there's too much dopamine activity in the brain, and the reason why we think that is because when we give medications that restrict dopamine, the patient gets less psychotic. And, in the case of medications that we have for, say, Parkinson's, for example, that increase dopamine in the brain, if they take too much of that, they'll get psychotic. And so we know that too much dopamine in the brain is associated with psychosis. And so one of the theories is that the person just kind of naturally has more dopamine in the brain. And then we've also noticed that with our second generation antipsychotics, if you look in your drug book, you'll notice they're antagonistic to serotonin as well as dopamine, so they restrict serotonin, and that seems to help people that have a psychotic disorder with their psychotic symptoms. So serotonin has been suggested as also a neurotransmitter that they have too much of. All right, so other biological influences. So viral infection, getting sick from the bacteria in cat feces. This is why when you're pregnant, the doctor tells you not to clean the cat box. Also, along the lines of viral infection, there's been more schizophrenic babies. People that eventually develop schizophrenia, they tend to be born at a time where when the mother was getting pregnant, it was flu season. So there's an idea that being exposed to the flu also, in utero can be linked to developing schizophrenia later in life. Histological changes in the brain, that's at the level of the tissue, that's been implicated, but that's beyond the scope of this lecture. All right, psychological issues, influences, we see it as a brain disorder, and so we don't see any more. There was once a time in the thinking about schizophrenia that it was somehow caused by the mother being too, not really being able to let go of the child when they're about to leave the household. That was very unfortunate because there was even a term for it called the schizophrenic mother, and it was like they were blaming the mother for causing the schizophrenia by being too clingy. And what this came out of was, when somebody gets schizophrenia, they regress. They become very childlike, and they have the needs of a child. And so it's natural, if you're the mother, to start taking care of them that way, because you see what they need. And so they just kind of had it backwards. It wasn't the mother was clingy causing the schizophrenia. It was the schizophrenia causing the mother to need to be more involved. And whoever's the primary caregiver, but especially at the time of this theory, like in the 70s and 80s, it was nearly always the mother. So just to be clear, that theory is debunked. It's no longer considered credible. But if you ever hear that term, the schizophrenic mother, you'll know that that's where that came from. All right, so environmental influences that could be predisposing factors. Poverty has been linked to the development of schizophrenia. And the thought around that is there's something called the downward drift hypothesis. And what that really means is when you've had schizophrenia go through your family several times over the generations, it's very hard. Let me put it a different way. It's very hard when you have somebody this ill in your family. If you have a child this ill, it's hard to work a double. You can't, that person needs care around the clock. And so it really makes it where it's tough to get ahead in life. And so it's common that when you have schizophrenia, the genes in your gene pool, sociocultural factors are that you're going to be more likely to be lower income level, because we kind of come from where our parents are at their level, and it's just very hard to get ahead when you have this illness that kind of sets back a family every few generations. Environmental influences, stressful life events, trauma, being abused, along with the kind of environmental influences that we put in ourselves, like drugs and alcohol, those can make the problems worse. Probably the worst one we see is people that go out and they're kind of lost, and they find methamphetamine. That's probably the worst drug we have as far as taking people totally back into their psychotic symptoms when they relapse on that. So the idea, schizophrenia is basically a biologically based disease. It's considered a brain disease, but those genes are expressed by the person's history, their trauma history, and whatever stresses from the outside and from the inside they've experienced. So schizophrenia is not the only psychotic disorder. We're going to briefly go over some of the other ones. The first one we'll look at here is delusional disorder. This is someone they don't hear voices, things like that, but they do have the delusions. And you see the term here, the existence of prominent non-bizarre delusions. What it means to have a non-bizarre delusion, it's something that's possible but not very likely. And so I'll give you an example with the erotomanic type. This is somebody that believes that, I'll give you an example. Let's say I believe that, I'm trying to think of a celebrity, that Britney Spears is my girlfriend, and I have this delusion that she's my girlfriend, and that we just need to be together, and she'll realize that we have this connection and we'll be together. And so that's considered a non-bizarre delusion because it's possible, it's just not very likely. A bizarre delusion would be that I have a girlfriend that's an alien from outer space, and she's gonna land a spaceship. And as far as we know, that's considered a bizarre delusion, because as far as we know, that's not possible. So that's the difference between a non-bizarre delusion and a bizarre delusion, if you ever come across that. Looking at the different delusional types, the grandiose type, that's and jealous, those are probably self-explanatory. The persecutory type feels like everybody's out to get them. Somatic type, the real common with the somatic type of delusions. A real common somatic type of delusion is to think you're pregnant, or to think you're disfigured in some way. Or I had a teenage girl one time tell me, when I asked that catch-all question at the end of the interview, is there anything else that I should know? She told me she believes her body is changing, but not in the way that she doesn't mean just in the way of puberty, but she felt like she's growing a tail, like where her tailbone is. She feels like there's a tail growing out of there. So that's a somatic delusion. Then mixed type is obviously it's a mixture of the different types of delusions. Brief psychotic disorder is brought on by, it's usually brought on by a stressful event. In fact, this used to be called brief reactive psychotic disorder. They dropped the specifier that requires it to actually be a reaction to something, but it's still called brief psychotic disorder. It has to, for it to qualify for this diagnosis, it has to be less than a month. And then after the month, they return to their normal level of functioning. So this is similar to a post-traumatic stress type of reaction. And I put the example on the slide here as a psychosocial stressor, like a midterm. Hopefully nobody will have a psychotic break after the midterm. All right, so substance-induced and psychotic disorder due to another medical condition. So those are other psychotic disorders. We've talked about how drugs can cause psychosis. Some of the other things here, lack of sleep can cause psychosis. We wouldn't call the hallucinations, especially the visual hallucinations with delirium, we wouldn't diagnose them also with a psychotic disorder if they have delirium or any of these. All right, so we also have catatonic disorder, which they changed the name a little bit. They used to call it catatonic schizophrenia, but there's also schizophrenia with catatonic features, or schizophrenia with catatonia is how you might see it in the chart. Catatonia can be a symptom. It's a symptom, and it's most often it's a patient with schizophrenia, but it can be with other things. But it's unlikely you'll see it with other things. But anyway, the most famous is where the person is stuck, and they're perfectly still and highly agitated. It's like they're shut down. That's how agitated they are. You'll see them standing perfectly still or laying perfectly still, and then you do their vital signs, and sometimes their vital signs are their blood pressure might be 200 over 120, and their pulse might be 140, and so they're not calm. They're kind of stuck still. It's almost like they're so psychotic they're shut down. So yeah, so they can be, if this kind of thing happens and there's nobody around, they can get very dehydrated and malnourished. So they're a big risk for dehydration and all of that. Another thing is if they remember they're highly agitated. So if you bring them out of it too fast, it can come out of it and become very violent. If you try to like move them around, they might snap out of it and be violent. So that can be dangerous. Um, I'll just share with you when I was new at Herrick on what was called a dual diagnosis unit with very very psychiatrically ill and also chemically dependent patients. Anyway, I noticed there was a patient standing perfectly still, and the nurse was in there to give the patient a shot, and he had 6 other guys with him because and I wondered, this person's perfectly still. Why are you having all this security with you? And I found out quickly because back then I was the group therapist, so I was going around to room, pulling, calling patients out of the room to come to group. And a few minutes later, after I saw the nurse getting ready to give the shot and all the staff standing around in the patient's bedroom, I hear a big crash, and then I go back in there, and all of the staff are laying on the floor, and the patient has he's like standing there perfectly still again in a slightly different position. And so I realized he had come out of it probably when he felt the needle go in to his shoulder, and was very violent and knocked them all down, and then went back into the catatonic state again. And so you have to be very careful with these patients. The shot that the nurse was trying to give that patient almost certainly was probably Ativan. Ativan's the treatment of choice for catatonia, and you usually have to do it IM because they're not in a state where you can really get them to swallow a pill. You do not want to be sticking your fingers in their mouth to place a pill because you might get your finger bitten off. And so that's why IM Ativan is generally the medication of choice for this kind of patient. You do have to take care to make sure they're secure because it can be very dangerous. And what's really important, realize the person is there. Even if they look like a mannequin, there's a person there, and you need to be treating them with respect and talking to them, telling them what you're going to do in a very calm voice, and you know, be very, give out a vibe of being very empathetic so that they know that you're there, not to harm them. Okay, one of our other psychotic disorders, it's called schizophreniform disorder. This is the pre-schizophrenic diagnosis. Remember, with schizophrenia, the person needs to have had the symptoms for at least 6 months. Schizophrenia is a very serious diagnosis to give a patient. Back in the days before we had equal coverage for mental health problems, and we had it where insurance companies couldn't deny you for pre-existing conditions. Sometimes giving somebody the diagnosis of schizophrenia meant that they would not be able to get health insurance in the future. So luckily that's not the case anymore, but still we don't give that diagnosis lightly. So schizophreniform disorder, if you ever see that, it just means the person they've had it longer than 30 days. If it was less than a month, it would be brief psychotic disorder. So they've had the symptoms more than a month, but less than 6 months. Schizoaffective disorder, these are kind of a little bit of symptoms that look like schizophrenia, psychotic symptoms, then also a lot of symptoms that look like bipolar disorder. So basically the differential diagnosis between the two is that the person with schizoaffective disorder, they'll still have some psychotic symptoms even when their mood is stable. With bipolar patients, when their mood is stable, they will not have any of the psychotic symptoms that you see in the mania or in the severe depressive episodes. Okay, as we go into the different symptoms of schizophrenia, we have we're going to focus mainly on positive symptoms and negative symptoms. And you can see here there's positive symptoms, hallucinations, delusions, disorganized speech. Also, a prominent feature of that is associative looseness, also known as loose associations. Then we have negative symptoms, blunted affect, something called alogia, poverty of thought. They don't have any motivation to do anything. Avolition, they generally get poor ADLs, and they don't experience pleasure. And so that's that. Then the emotional or affective symptoms, dysphoria. Sometimes they have a very serious suicide attempt, especially when they're having their first psychotic break. And hopelessness. And then cognitive symptoms. This is why when I hear cognitive behavior therapy recommended for a psychotic disorder, it makes no sense, because this is a big part of what's sick in this patient is their cognitive ability. So cognitive symptoms, they can't remember, they don't have good attention, they're distracted. They also have a lot going on inside, usually a lot of what we call internal stimuli, where they're hearing things and having a lot of trouble with their thinking. So of course they're not able to pay attention to the outside world very well. They have impaired judgment, and there's no real logic to their thinking. All right, so positive symptoms. So one way to think about positive symptoms, which I'll talk about a little later as well, is things that are there that should not be there. So we don't mean positive and negative in terms of good or bad. We mean positive as in things that are there that shouldn't be, and negative as things that are missing that should be there. And so content of thought, so they have delusions. What we call delusions, they're like a false fixed belief. They don't come and go a lot. The false belief is usually pretty consistent. They usually have an obsession with religion, whatever, if they have any kind of background of religious beliefs. And it makes sense if you start hearing a voice out of nowhere to think, there's maybe it's God, or maybe it's something along that nature. Then paranoia, and this kind of illogical, magical thinking that they can have. And we'll go into that a little later as well. So form of thought, we talked about loose associations, neologisms. Those are words that only have meaning to the patient. They're not real words, but the patient has made them up. Sometimes babies do that as they're learning to talk, but it's very different, because usually these made up words have some kind of important meaning to the patient. So we need to find out what the meaning is to the patient, because that might be important. Concrete thinking, everything is very literal. What brought you into the hospital? An ambulance. Those kind of very literal kind of answers to questions. Clang associations. This is one where they're saying something, it doesn't make sense that these are grouped together, but they rhyme. And so an example of that, we had a patient last semester where he kept saying Jesus, 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 and there's no logical connection to Jesus and Jesus, but the only thing is that it rhymes, and so that's why that patient was saying them together. So form of thought continued. So word salad, where the words are just kind of thrown together, they don't match at all, and it doesn't make any sense, obviously. Circumstantiality, where they sound like they're getting to a point, but they never really get to a point. Bring in a lot of things that are unnecessary, tedious details, kind of a little bit like my wife when she's had too much coffee. Tangentiality, inability to get to the point, bring in too many new topics to get to the point. And then mutism, inability to speak or refusal to speak. And what's most common is you'll see a patient that's selectively mute. And generally the way they decide when they're going to talk and when they're not, when you want to ask them something, they generally don't answer. And then when they want something, they suddenly can talk. And so that's that's more common than just not talking at all. And then we also have perseveration, where they get focused on something and can't let it go. Sometimes it'll be a word or idea. Probably the most common one I've seen is they'll be focused on discharge. There's something called thought broadcasting, where they believe their thoughts are being broadcast out to the world and other people can hear their thoughts. That's why a common thing you'll see with a mentally ill person is they'll put something on their head, some tin foil, or I've seen a woman in downtown Berkeley with a construction hat, hard hat, and that's because they want to, they're trying to make it where other people can't hear their thoughts. You can imagine how uncomfortable that would be if you were walking around in the world and you thought other people could hear what you're thinking. That would be very, very disturbing. I don't know why. There's a common feeling that aluminum foil would help keep people from hearing your thoughts if you had that kind of belief, but that is a common thing we see over and over again. Thought blocking, this is where a patient, you can tell they're trying to answer you and they have something to say, but they just can't get it out. They just can't push it out. They get kind of stuck mid-sentence. I always feel like this should be called thought constipation, because it's hard. It's like when you're constipated, trying to have a bowel movement. You just can't push it out. And so, yeah, thought blocking is what that is. And so thought insertion, that's the belief that other people can insert thoughts into your thoughts. And then thought control, kind of a belief that someone else can be controlling your thoughts, or that you can control other people's thoughts. So perception, and this is, through your senses. And so some misperceptions that we can have when we're hallucinating. Auditory is by far the most common one. Hearing voices or hearing sounds, by far the most common type of hallucination, followed by visual hallucinations. Remember, with a psychotic disorder, we can tell the visual hallucination is from a psychotic disorder because it's generally far away. The hallucinations, they're kind of dark figures or kind of menacing in the back of a room, or just out of the corner of your eye, that kind of thing. Whereas the kind of visual hallucinations you have from delirium, when there's like an organic thing going on with your brain, those are really close. Those are the visual hallucinations with something like delirium. Those are where you see a patient picking at bugs. They think there's bugs flying around them. Those are more associated. Those are from delirium. Those aren't from schizophrenia or psychosis. All right, so tactile hallucinations, where you feel something on you, usually like bugs crawling on your skin or bugs crawling under your skin. Gustatory, where you're hallucinating a bad taste. Usually not something, it's usually something repulsive. The ones that I've heard of before, somebody constantly tasting semen or tasting feces, or it's too bad we don't have gustatory hallucinations that taste like chocolate or something like that. Then we have olfactory hallucinations. Again, it's usually something unpleasant when you're smelling something that is not there. And then general somatic sensations. And I think I gave the example earlier where the person thinks they're pregnant, or they have some kind of deformity, or they don't believe a part of their body is there that is obviously there. Or I gave the example previously of the teenage girl that thought she was growing a tail. And then illusions are where the person, they're not they're perceiving what's actually there, but they're misinterpreting what it is. So that would, an example of an illusion. When I was a child, I had the front bedroom in the house, and the house across the street, they sometimes would leave their porch light on late into the night, and they would, on a windy night, the tree that was in front of their house, the light behind it would make shadows on my drapes in my room that looked to me, as as a child, I thought that was a monster, but actually it was just the shadow from the trees blowing around. But so I was seeing what was actually there. I just had a different thought about what it was based on being a kid. Okay, other positive symptoms: echolalia, repeating words that are heard, and sometimes they'll say exactly what they hear you say. And with both echolalia and exopraxia, where they repeat the movements that they see, um, they're not repeating what you say to mock you or to make fun of you. It's because identifying with you makes them feel more secure. It's actually a compliment that they see you as somebody that's strong, and or having something that they're lacking at the moment, and so they're trying to be like you. Um, it kind of reminds me of when you're a little kid and the other little kid is trying to bother you by every time you say something, they say the exact thing, or they make fun of your walk by walking behind you. Um, in schizophrenia, they're not doing that to make fun of you. They're doing that because they want to identify with you. All right, and so that's what we're talking about with the identification and imitation. They're trying to be like someone else because they're basically they're afraid and insecure. Then we have depersonalizations, feelings like things are not real, um, and they're not, you know, they're not really who they are. All right, moving on to negative symptoms, and you guys hopefully by now you know what affect is. Inappropriate affect, emotions that don't make sense in the circumstance. Um, kind of feels like they're not really there. They have a weak emotional tone. They have what we call a flat affect. You'll also see that with people that are very depressed. And then they're really not interested in what's going on in the environment. They're pretty apathetic. They're more focused on what's going on inside of them. Avolition, which means they really won't do anything. They just kind of sit there staring into space. They usually have very poor ADLs because they're difficult to motivate to shower, and they don't care. They really don't care what they look like. And so they're very impaired in their relationship to the external world. They're very focused on their internal world. And so they have poor social interaction, and they tend to isolate themselves. Their psychomotor behavior, they have a deficiency of energy, what we call inertia. If you have a patient that's very, very catatonic, they can get stuck in these poses where it's called waxy flexibility, which means they're catatonic, and if you move their arm a little bit, it'll just stay there. And they won't resist you, they'll just let you do that. There's something that's called a test of waxy flexibility. If you call a doctor and tell them that your patient is standing still in the hospital for a long period of time and they appear catatonic, the doctor might ask you to perform a test of waxy flexibility. What that means is you just walk up by the side of the patient and you're going to just gently lift their arm up a few, 3 or 4 inches, and then just let it go. And if they don't have waxy flexibility, just like a regular person, their arm would just kind of fall back to their side. If it does have waxy flexibility, it'll stay in the exact position that you left it in. And that's considered much more along the lines of the catatonic spectrum than if they don't have waxy flexibility. So the reason the physician would ask you to do that is because they're trying to determine how much medication does this patient need. Generally, what they give for a patient that's catatonic is just like 1 milligram Ativan IM, and probably with waxy flexibility they would give 2 milligrams of Ativan IM, and they might give an antipsychotic in addition. So posturing, they'll get these postures usually in a position that's kind of in the way. Then there's a lot of pacing and rocking as well. So some other features, anhedonia, which you remember from the mood disorders lectures, very much associated with depression, where you just can't experience, you might do things that felt good in the past, but they don't feel good anymore. And then they're regressed, just like they're very childlike in their thinking. And one way to remember the 6 of the negative symptoms, they start with the letter A. So you have anhedonia, avolition, asociality, affective blunting, and apathy and alogia. So that's just one little. And like I said, a good way to think of it is positive symptoms are things that should not be there. They're there, but they shouldn't be. Negative things are the absence of things that should be there. All right, so there is a risk for violence with this diagnosis. Sometimes it's not politically correct because we don't want people to be scared of our patients. But the reality is, even though most patients with schizophrenia are not more violent than a regular person, there are some people with schizophrenia that are much more violent than a regular person. And so this is a common nursing diagnosis, risk for violence. It can be self-directed or other-directed. Like I've said earlier, especially patients with their first psychotic break, they're at a very high risk for a serious suicide attempt. But they're also a risk to be violent with other people because of the paranoia, the suspiciousness, their panic. Like I mentioned earlier, there's the type of catatonia where there's catatonic excitement where they're running around. They can have rage reactions usually in response to something going on internally. They can have command hallucinations to harm other people. And so that's really dangerous. More common are hallucinations to harm themselves, but they can have hallucinations that are commanding them to harm you. And so it's really important when you have a patient with auditory hallucinations that tells you they're hearing voices, especially if they're saying the voices are telling me to do things, you need to follow up with what are the voices telling you to do. All right, and just something I'll add here, because of sometimes the religious delusions are dangerous, we generally don't allow them to have a Bible in the hospital. We'll refer them to the hospital chaplain, and the chaplain will come and talk to them. Chaplains in a hospital with a psychiatric unit have usually been trained how to deal with religiously preoccupied psychotic patients or even manic patients that have religious preoccupation. Um, and sometimes they'll, generally, if it's somebody from the Christian religion, they'll if they are going to leave them a Bible, they'll leave them just the New Testament with the more, it's more of a peace-loving Jesus focus versus like an angry, vengeful God focus, like in the Old Testament. And so that can get a little confusing sometimes. But remember, when you read, especially the Christian Bible, there's some verses in there, if you're not in your right mind, that you could take out of context in a very dangerous way. So that's why we wouldn't offer, we wouldn't allow that. But we definitely want to support them with their chaplain. All right. Okay, so some outcomes we're looking for is that the patient develops an ability to relate to other people, kind of gets out of themselves a little bit, recognizes when their reality is distorted. Um, we definitely want them to not have harmed themselves or other person during their treatment, and to have at least somewhat of a realistic perception of themselves. We want them to be able to demonstrate to be able to see the environment correctly, have their anxiety manageable. And it's interesting to phrase it this way: relinquishes the need for delusions and hallucinations. Um, Even though these are symptoms of schizophrenia, they're seen as a defense mechanism against certain things going on kind of in the unconscious mind. And so it's thought that when they're better, they won't have the need for those kind of artificial perceptions. So other outcomes that we want is they should be able to have some kind of trust in other people, um, interact verbally, and take care of their ADLs. That's usually one of the last things, but that's definitely a sign that they're doing better. In fact, one of the things that I would say to patients that are trying to get themselves discharged is that, if you come in to see the doctor, and the doctor, if the doctor's surprised to see how well put together you are, that you've had a shower, your hair is combed, your teeth are brushed, and you're looking good, the doctor's gonna believe you when you say that you're in a better place. All right, so the family, like I mentioned earlier, there's a lot of denial in the family, and that can be very difficult to overcome. So we really have to work with the family to understand what they're dealing with here. Sometimes we'll even refer them to family therapy so that they can make plans on how to deal with the patient. Um, like you see here, we don't know the exact cause of schizophrenia. We have our different theories. We have isolated gene clusters that are associated with schizophrenia, but we don't know why some people that have those gene clusters don't develop schizophrenia. But our idea is that it's a combination of genetic factors and stress that causes the actual schizophrenia disease to manifest, to come about. So National Alliance for the Mentally Ill, that's an organization that's run by more by families of psychiatrically ill patients, and they also have a California organization that's related to it called the California Alliance for the Mentally Ill, or CAMI, and they have a lot of different resources, support programs for family members, ways to get kind of share information about resources. So our treatment modalities, when we say social treatments, we mean in milieu therapy, we mean in the hospital. somebody that's had a first psychotic break, they need to be hospitalized to be safe. And so we have our milieu therapy, and then the other big thing that they really need is medication. The kind of things that are happening, um, our medications work as far as helping them with their psychotic symptoms, and the sooner we can get that going, the better. And then with family therapy, usually it's family therapy for the family that doesn't include the patient in the therapy room, but it's focused around how to manage the patient. It can be very stressful on the family. Then we have the recovery model of similar to if you're familiar with the way the recovery idea is for people with a chemical dependency issue, that you don't ever see yourself as cured. You see yourself as in recovery. So you still have the illness. You just it's not ruining your life at the moment, but you're kind of doing the best you can with what you have. So there's employment programs where they try to help you get a job that where the employer knows you have a psychiatric illness, and they kind of make allowances for certain things. Um, in the recovery model, it's seen as a process. Recovery is a process, and so there's not an end point. It's something that you do throughout your life when you have this kind of psychiatric illness. Like I said earlier, with something like schizophrenia, the person never really returns to the person they were before they the illness emerged in them. They're different forever, and so just kind of dealing with that reality, trying to make a life worth living in the circumstances. It can be challenging, but it's something that even if you don't have a psychiatric illness, that's what you have to do in your life, is deal with whatever your realities are in your life and make it work, make the best of it. It's a lot more challenging when you have a diagnosis like this, but it's still, it's viewed as a lifelong process. So our main treatment is psychopharmacology, antipsychotic medication, and it's used in the short term to decrease the agitation. Along with you've probably noticed that if you're in a psychiatric rotation, you've probably noticed we use these medications to decrease agitation in people, even if they're agitated for another reason and they're not psychotic, 'cause they do work very well for that. But for people that have a psychotic disorder, have a schizophrenia or one of the other ones, it works, they work pretty well to at least decrease the intensity of the hallucinations the person is feeling and the paranoia. And so they're very effective medications. There's side effects we're going to talk about, and there's serious side effects. Part of what's really important as a psychiatric nurse, or even a nurse in general, is to be able to spot these kind of side effects early on. All right, so we have our two generations of antipsychotic medication. The first generation, called the typicals, they mainly block dopamine, and so they mainly only work on the positive symptoms. The atypical antipsychotics, they block both dopamine and serotonin, and they treat both the positive and the negative symptoms. This was a significant breakthrough when the second generation of antipsychotics came out, because um, we didn't have a lot that really helped with the negative symptoms, especially when people have that in the maintenance, the residual stage of their illness in schizophrenia. Um, and so that helped a little bit. All right, so here's a list of our main first generation, also known as conventional, also known as typicals. All should be very familiar with these medications by now. Then they have our second generation medications, and I have you learn more of them, and there's more of them coming out all the time. This is definitely not an exhaustive list, but these are the main ones that we see in the hospital. All right, so prior to starting atypical antipsychotics, there's a list of tests that you'll need to know for the NCLEX and for my exam that will be ordered on the patient. They need to get an EKG, because one side effect of antipsychotic medication is they can increase the length of the heartbeat. The QRST interval, especially at the ST. Sometimes when you see it, if you see it in a textbook or on a question, it might say QT interval, which just means the whole heartbeat. So either one of those is actually true. But anyway, you have to have an EKG beforehand to make sure that the person doesn't naturally have a little bit of a prolongation in the heartbeat. If they do have that kind of thing naturally, which is it's rare, but I have seen it a few times, then they cannot take this class of medication. So also we have to make sure that they're not pre-diabetic or on the verge of becoming diabetic. These medications can, and I'm talking about the second generation atypical antipsychotics, they can raise your blood sugar. And so they can cause weight gain, they can cause metabolic syndrome, where it's this whole thing where you crave food and your blood sugar skyrockets. So we have to get an HA1C to find out how their blood sugars have been the last 3 months. We need to get a lipid panel, and sometimes the doctor will order a fasting capillary blood sugar for a day or two, especially in the morning, just to get an idea of where the patient is with their blood sugar. All right, so some other side effects of antipsychotics, and these are for typical and atypical. There's sedating, which is one of the things that we're looking for sometimes. Orthostatic hypotension, photosensitivity, so they should be advised to wear sunscreen and hats when they go outside, especially if they have if they're from a race that's light complected. Like we said, that it can cause a little prolongation in the heartbeat, so we need an EKG. I mean, we can have EKG changes. It can make you salivate too much, and that's primarily the first generation antipsychotics that cause the hypersalivation. Can cause weight gain, which is primarily the second generation antipsychotics, along with the hyperglycemia is primarily the second generation antipsychotics. We found out through research that there's an increased risk of sudden death in frail elderly patients. One of the things that we used to do with patients that have dementia or delirium and have sundowning, where they get agitated at the end of the night, is give them a little bit of a low dose of an atypical antipsychotic, and it was found that sometimes in very frail patients that could cause sudden death. So we have the side effect of granulocytosis, which is primarily clozaril. It's possible with the other ones, but clozaril is the one where we have to watch it very closely, because it's a much bigger problem with that medication. Clozaril, I think we'll talk about it somewhere else in this lecture as well, but it has to be, the doctor has to register you with the government, and the government kind of makes sure that the doctor is following the protocols. That's how serious the side effects are from clozaril. We have extrapyramidal symptoms that we're going to talk about in detail later on in this lecture. The same with tardive dyskinesia and neuromalignant syndrome. All right, extrapyramidal symptoms. And so our main ones here, Parkinsonism, which is it's like a fake Parkinson's to say the literal of what this kind of jammed together word means. And basically it's the restriction of the dopamine. It makes the person develop what looks like Parkinson's, because that's what Parkinson's disease is. It's a depletion of their dopamine. And so this happened a lot with the first generation typical antipsychotics, when patients would take them over a long time, and probably was a sign that they were getting a little too much, and so they would have less dopamine than they really need, and so start to get Parkinson-like symptoms. We have akathisia. This is continuous restlessness and fidgeting, and this can be miserable for patients that have it really bad. We have dystonia, where a patient gets kind of stuck. Their jaw can be thrust out, and their head can be rotated to one side. It's very scary to the patient. Generally, it doesn't, it's not really deadly, but it is terrifying. The same with the next one, oculogyric crisis, where the eyes roll back in the head and they're kind of stuck, and that's also terrifying. Suddenly, you can't see when your eyes are in the back, kind of rolled up like that, and so that's very scary for patients. And our treatment basically for EPS is simply Benadryl 50 milligrams IM or Cogentin 2 milligrams IM. These anticholinergics work similar, and they work very fast. A patient that's, if you catch it really early, you can give it PO, but generally patients, especially if they have dystonia, they're not going to be able to take a pill very well, so they need an injection. And in cases where you can't give the pill, and the patient for some reason can't have an injection, or is very terrified of an injection, it is available as a suppository that can be given that way as well, if that's what you think your patient would be able to tolerate. Most people in a crisis situation don't want a rectal suppository, but I notice we do have it available in our emergency meds if that's a situation we come into. All right, so the key to being a good nurse is catching things early. What I found is these three early symptoms that you'll get from a patient. It kind of shows they're on the road to developing, and what I'm talking about here is like the dystonia and oculogyric crisis kind of thing. And so they'll come and they'll tell you, my tongue feels a little weird. Is my tongue swelling up, or just anything like that. That kind of tells you they're kind of going down that road. The other thing, a second thing, is their eyes will tend to drift up. They'll you'll walk by and it looks like they're looking at the ceiling. They can bring them down if you ask them. If you say, hey, look at me, they'll come down and look at you. But when you leave them alone and they're just on their own, their eyes will drift up like they're looking at the ceiling again. And then they'll start to experience stiffness in their upper back and neck. And that's, those three, especially those three all happening at once. You have some time. You can usually, if you catch it early, you can give them some, either usually a patient has PRN Cogentin or Benadryl ordered PO just in case of EPS, if they're on a medication, one of the medications that's known for causing it. And so you can interact early with this and take care of it before it becomes a problem. All right, one of our bad side effects, and this happened a lot with first generation antipsychotics, is tardive dyskinesia. This constant grimacing, smacking of the lips, head and shoulders twisting in a weird snake-like motion. This the problem with this is it doesn't go away once it develops. So we have to be very careful to catch it early and make sure the meds are changed before it can develop into something that they're going to have to live with the rest of their life. So these are usually the Ames test here, the abnormal involuntary movement scale, primarily given in the outpatient setting when they're being monitored with their meds as an outpatient. We can do that on an inpatient setting if we're worried about it, but generally it's the people that are monitoring them that they're checking in with doing their med checks that are following them as an outpatient that hopefully they catch this kind of thing early and they do the Ames. So you can see the Ames test there. That's goes over all the different movements and things that go on with tardive dyskinesia. All right, so NMS, neuroleptic malignant syndrome, it's very rare, potentially fatal. So this is a medical emergency. The symptoms: high fever, muscle rigidity, tachycardia, and trouble swallowing, drooling. Sometimes that can look like different things, but it's very intense when you see it. I think in my career, which is over 30 years in psych, I've probably only seen it. I've seen it twice. Once for sure, and once that we weren't quite sure if that's what it was. And so it's pretty rare, but it is something that happens usually after we've aggressively given them a lot of antipsychotic medication. Primarily, this happened from first generation antipsychotic medication, but it's possible with second generation as well. And the treatment, it's if you're familiar with malignant hypothermia, it's similar. Um, that's a condition people get from after surgery sometimes from the kind of medications they have during a surgery. But anyway, you discontinue the antipsychotic immediately, and then there's dantrolene and usually both of them, if possible. These medications can be given PO or IV, and that's what helps reverse it. All right, so clozaril is a second generation antipsychotic. It's it's our most powerful medication these days for somebody with a psychotic disorder. It is very beneficial in reducing suicidal feelings as well. It's one of those 3 biological treatments out there in the field that are well known to reduce suicidal feelings in people, well documented, well researched, and also very effective in reducing psychotic symptoms. And so one of the things to know is it's has a lot of side effects, but we still use it for patients that need it because it's so effective in what it does. The big risk is the granulocytosis, which is potentially fatal due to the white blood cell count can drop to extremely low levels. And so those have to be checked every week before the patient gets that week's doses, and the government follows these cases to make sure the labs are getting done. The big thing that you need to know as a nurse with clozaril is that any sign of infection, stuffy nose, a little bit of a sore throat, you have to take it very seriously that could be a sign that their white blood cells are crashing, that they're dropping, and the patient is being, catching every little infection possible because they don't have any defense. And so we have to take it very seriously. Any sign of infection, any mild temperature, any sore throat, any stuffy nose, anything like that, we take it very seriously. All right, and this is patient family education for Clozaril specifically. One of the big things about Clozaril, the patient has to have somebody, usually a family member, that is able to take them to get their blood drawn every week before they get their week's dose of the meds. And so that has to be established before we start a patient on Clozaril, that there's somebody in their life that can do that for them. And then just like with the other antipsychotics, they need to use sunscreens and not be in the sun a lot. All right, so psychosis and suicide are big worries about that. Command hallucinations, when a patient tells you they're hearing a voice telling them to hurt themselves or hurt other people, what you really have to do is ask them, do you feel like you have to do what the voice says? And, some people will say, no, the voice, that's just like something that's there bothering me, but I can tune it out. But other people might say they think that voice is the voice of God commanding them, or the voice is some kind of demon that's going to harm them if they don't follow what it says. And so that's very important. If the patient thinks that it's the voice of God and they have to do what the voice is commanding them to do, then you have to take action and put that patient on a one-to-one. You might need to get emergency medication to interrupt those voices and keep the patient safe and other people. And then we have number 2, thoughts or feelings of alien control, feeling like some other force is in control of them. So that might be a patient that, you say, have you been having thoughts of killing yourself? And can you agree to be safe on the unit? And the patient might say, well, yeah, I would never hurt myself or anyone else, but I'm not the one in control. So if they feel like someone else is in control of them, that's very dangerous as well. And you might need to assess them for a higher level of observation or emergency medication. Then number 3, we have our hyper-religious ideation, where the patient believes they need to sacrifice themselves, in the manner of like the way Jesus had to sacrifice his life. And that this can take different forms of, it can be killing themselves, it could be cutting off their arm, it could be cutting off their penis, it could be any number of things. And so that also can be very dangerous. This is one of the reasons why we try not to let a patient read a Bible that has a psychotic disorder, and instead we refer them to the hospital chaplain. Hospital chaplains are that are in psychiatric units. They have been trained in how to deal with patients with a religious preoccupation. All right, so let's take a look at the objectives and go over that really quick. So the first one here, be able to list some typical behaviors that mark the very early symptoms of schizophrenia. So we talked about that very early, before it's really a phase of schizophrenia, but we call it that prodromal phase. We talk about they start to be a little odd, they start to withdraw, they might get a little religiously preoccupied. Those are signs of the very early stages, and what we call the prodromal phase. Then the difference between positive and negative symptoms of schizophrenia. We talked about all those different ones, and positive symptoms are things that are there that shouldn't be there. Negative symptoms are things that are not there that should be there. All right, and then common features of schizophrenia, thought broadcasting. We talked about that as, thought broadcasting is feeling like other people can hear your thoughts. It's kind of like you're broadcasting your thoughts out of your head. And typically you'll see patients that they think they have to put tinfoil or some kind of covering on their head to keep people from reading their thoughts. Thought blocking, where a patient, they're trying to express themselves and they get stuck, and they they might get stuck mid-word. It looks a little bit like aphasia, but not quite, because and it's really it's not a it's you can tell the patient really has something they want to communicate to you. They just get stuck. Like I say, one of my things is I call it thought constipation, because they just can't push out the thought. Okay, we have ideas of reference, where they believe things are about them. The weatherman touched his nose. It's a signal to me that I'm supposed to, run away, or something like that. Believing things are about them. Neologisms are made up, are words that only have a meaning to the patient. They're not real words. They're words that the patient kind of has created themselves. Echolalia, that's when a patient is saying the words that you say, kind of mimicking you in a way to try to identify with you. Energia is a lack of physical energy. Thought insertion is a belief that someone else can insert thoughts into your mind. And thought control is that some outside force, some alien force, can control your mind, control your thoughts. All right, so to be able to differentiate between brief psychotic disorder, delusional disorder, and schizoaffective disorder. So brief psychotic disorder, that's a psychotic disorder that's less than 30 days. Usually it's a reaction to some kind of extreme stressor, but that's no longer a requirement that there's an extreme stressor. It's just they're psychotic, but it's less than 30 days. Delusional disorder is a long-term fixed delusion that person has these delusions, and they don't really have a problem with their perceptions. They don't hear voices or anything like that. And we have schizoaffective disorder, which is a pretty common diagnosis to see in the hospital, and it kind of occupies the territory between something like schizophrenia and something like bipolar disorder. It has features of both. The person can have delusions, hallucinations, but they also can have mood swings, pretty decent mood episodes. The way that you tell the difference between somebody with schizoaffective disorder and say something like schizophrenia is the schizoaffective disorder patient, they usually don't have a lot of negative symptoms. First of all, they'll hear voices and have the delusions, but they don't have a lot of negative symptoms. And you can tell the difference between schizoaffective and bipolar, because with the person with bipolar disorder, they have psychotic symptoms in mania, and they have psychotic symptoms sometimes in their extreme depressive episodes, but they don't have any psychotic symptoms when their mood is stable. Whereas patients with schizoaffective disorder, when their mood is stable, they'll still have some psychotic symptoms in there. They'll still have a little bit of delusions. They'll still have some voices maybe. And so, yeah, so even the name is kind of, we used to call mood disorders affective disorders. And so it's kind of like they've shoved them together, those schizoaffective. All right, and big difference between typical and atypical antipsychotics, the neurotransmitter that is affected with typical antipsychotics is dopamine primarily, and then with atypical antipsychotics, it's a restriction of dopamine and serotonin as well. All right, so you need to be able to recognize and explain the side effects of antipsychotic medications. Some of the primary ones, dystonia, that's the one where they kind of get their head stuck to the side and tongue sticking out, and then we have pseudo-Parkinsonism, where usually as a result of long-term first-generation antipsychotic medications, they look like they have Parkinson's from having their dopamine restricted too much. Akathisia, where they're having a lot of movements that they can't control, and a lot of feelings of restlessness that are very uncomfortable. Oculogyric crisis, that's where the eyes go back and kind of get stuck in the back of their head, like where they can't see, and that's terrifying. Tardive dyskinesia, it's a muscle movement disorder of the face, mouth, and neck that is permanent. So we try to catch that as early as possible so that the patient doesn't end up dealing with that for the rest of their life. And then we have our most serious one in terms of life or death is NMS, which is neuromalignant syndrome. And so you also want to be able to list the treatments for those. All right, so continuing on, you want to be able to explain the cause of schizophrenia to family members. One way to look at it is you don't want to tell them what we don't know. You want to tell them what we do know. So we don't want to tell them we don't know in reality, we don't know the exact cause, but we do know that there's a genetic vulnerability, the diathesis part, and then the stress part, the environmental stresses. And so basically the thing to say to family when they ask you is it's a combination of genetic factors and stress. Understand the different types of hallucinations, the auditory, visual, tactile, gustatory, olfactory, and general somatic sensations. What symptoms make a psychotic patient a high risk for suicide? We talked about that just a few slides ago, but the symptoms are having command hallucinations to kill yourself, having a feeling of alien control, like there's a force outside of you controlling you and making you do things. And then the third one is the hyper-religious feelings that a person needs, that the patient feels like they need to sacrifice themselves, like Jesus Christ in the Christian religion. All right, and then the risk benefits and treatment protocol unique to Clozapine. So the risks are the granulocytosis is very dangerous, where the white blood cells break down and makes the patient basically helpless to any infection that comes along. The benefits are it is our most effective medication for psychosis, and it's one of our most effective treatments for patients that are chronically suicidal. And the treatment protocol for the first 6 months they're on Clozapine, they have to go and get their WBCs checked every week before they can get their doses of the medication for the following week. If there's no problems after that 6 months, then they can go to every 2 weeks. And I've heard that they're going to try to make it where if there's no problems that first year, then they can make it like every month. I don't know that that's in place yet. It's possible that it is. But yeah, that's kind of a very detailed, this treatment protocol was actually on the NCLEX when I took the NCLEX back in 2007. And I thought that's a very piece of specialized psych knowledge that I was surprised was on the NCLEX. All right, and then understand how visual hallucinations look different with schizophrenia than they do when there's an organic cause like in delirium. And so So remember, with schizophrenia, the visual hallucinations are they're usually far away and kind of out of the corner of the patient's eyes, long ways away. Not a long ways away, but like across the room. Whereas delirium, they're right up front. The patient thinks there's bugs flying, and you'll see them sometimes trying to kill bugs flying in front of their face when there's no bugs there. I've had a patient before that had delirium who she was reaching on the ground, um, and I asked her, what are you reaching for? Because there was nothing there, and she said she had dropped her cigarettes and she was trying to pick up her cigarettes. And so the hallucinations are close with delirium. They're far away with schizophrenia. That's a very easy way to remember that. All right, so some practice questions. The client hears the word match. The client relies a match. I like matches. They are the light of the world. God will light the world. Let your light so shine. Which communication pattern does the nurse identify? All right, I'm going to give the answer. You can stop the recording real quick if you want to try to think about it more, but I'm going to go ahead and give the answer. The answer is loose associations. Okay, number two, a patient or a client has been taking thorazine for several months, presents in the emergency department with extrapyramidal symptoms of restlessness, drooling, and tremors. What medication will the nurse expect the physician to order? A, paroxetine Paxil, B, carbamazepine or Tegretol, C, benzotropine or Cogentin, or D, lorazepam Ativan. Again, if you want to take a minute to think about this question, go ahead and pause this recording because I'm going to give the answer right now. The answer is C, and it is Cogentin.